Well, that being said, maybe it's good to just get started. And it is being recorded, as Caitlin mentioned, so everyone will be able to go back if you've missed the beginning. Also, we will send out certificates for the CME credits that are associated with this webinar as well. So I'm Shannon Burke. I'm the Director of Regional Programs at Lakeridge, which includes the Regional Cancer Screening Program as well for the Central East region of Ontario. Happy to be with everyone today. I think this is a really important topic and something that certainly has been in the news as of late, as we have new changes to guidelines in the Ontario Breast Screening Program. So happy to have with us today Caitlin Loudon, who's the Primary Care Engagement Lead, Dr. Rebecca Ray, who's the Primary Care Physician Lead, and Dr. Rula Shaheen, who is our OBSP lead for the Central East region. So I'll turn over to Becky, and I'll just go off camera myself so I can listen in and eat my lunch while I listen.
Perfect. Thanks, Shannon. And thank you for everyone joining us today. I had the opportunity actually to spend a little bit of time outside just before coming over because we had the grand opening of our healing garden at Lakeridge Health Port Perry this afternoon, well, late morning, I guess. And we're having a little spirit barbecue for the staff over there today. So it was a nice opportunity to run out. So my cheeks are a little bit flushed because then I ran back over to the office to be here. I am Dr. Becky Ray. I am the Regional Primary Care Lead for the Central East Regional Cancer Program, and I am very excited to have Dr. Shaheen with us today. Dr. Shaheen has a very full agenda, so I will hand it over to her after I introduce her. So I just want to give you all a little bit of background. So we're really lucky to have Dr. Shaheen leading our breast and cancer imaging, being the breast and cancer imaging lead and leading our OBSP program here in the Central East region. Dr. Shaheen is also the Chief of Radiology and the Medical Director at the Peterborough Regional Health Centre since 2015. And she's also the Regional Breast Imaging Lead for the Mississauga, Halton and Central West regions since 2016. She was the Provincial Clinical Lead for Mammography Quality Management Partnership, a joint program at Cancer Care Ontario and the College of Physicians and Surgeons from 2016 to 2019. Dr. Shaheen completed the Global Executive MBA in Healthcare and Life Sciences at University of Toronto in the class of 2021 and is the founder of the Women's Imaging and Leadership Lab. So without further ado, Dr. Shaheen, thank you for being here.
Thank you so much, Vicky, for the kind introduction. I don't want to delay you guys, so I'm gonna try to share my screen. I hope it will work. We tried it, so it should work. And I'll bring up my talk. Please let me know if you can see it. I hope you are.
We can see that, okay.
Okay, so thank you again for having me. I'm happy to talk about a couple of important things that are pertaining to our Ontario Breast Screening Program. And as an organized breast screening program, there are some changes that are coming. Things already have happened, and we're going to go through the rationale. So we're going to talk about three important things: breast density, supplementary screening, and screening for women under the age of 50. Let's start with the breast density. As we know, mammography is the standard screening tool for detection of breast cancer, but we know it has some shortcomings, such as 10 to 30% of cancers may be missed with mammography. And one of the most important reasons for that is the fact that women have variable breast densities that compose their breast tissue, which would look very dense, as this woman here on the left. And when it's fatty, it's easier to detect the cancer. So what is breast density? It's the breast composition. It's the amount of fibroglandular tissue in relation to the amount of fatty tissue. Fatty tissue looks lucent, which means like more gray, and the fibroglandular components appear radio-opaque. That's a radiographic term. So basically, it's more white. So it varies greatly throughout the woman's life. Could be due to endogenous causes or exogenous causes. So it will vary with age, parity, body mass index, even ethnicity. For example, we'll see women of Asian heritage, basically, they will have higher density and smaller breasts. Smoking, alcohol, obesity, and sedentary lifestyle, as well as oral contraception or hormone replacement therapy can impact density. For example, we ask that question for women, postmenopausal women who all of a sudden the density has changed. We ask if they are taking any hormone replacement therapy, and most of the time they do. So why breast density? Okay, why it's very important to bring it up and how it impacted some of the decisions that came into OBSP. So the high breast density is actually a risk factor. It's an independent risk factor that would increase the risk for breast cancer. Also, women with dense breasts, they will have reduced performance of screening mammography, as I explained earlier. So this would also be reflected in the higher interval cancer rates. So interval cancer is defined by the fact that a cancer can be detected in the interval between the two planned screening visits. So basically, a woman, let's say, had a screening mammogram now in May, and she's supposed to have her annual or by every 2 years screening in 2 years. So let's say she presents in September with a palpable luminous cancer. That means it has been missed, or I would say it has been covered by something which could be the breast density. Reduced also the breast density, the higher the breast density, it will reduce the cancer detection rate, which means that it will increase the mortality rate when it comes to screening of women with dense breasts. Also, there are more advanced breast cancers in dense breast women when we compare it to those women who don't have dense breasts. And when they are screened regularly, the mortality reduction is actually lower in women with dense breasts. So because of all of the above, really there are challenges when it comes to screening those women, because not just like only for the masking effect, there will be also rapid growth of the tumor without noticing it. It's an independent risk factor. It has even a high rate of locoregional recurrence. If the woman has been already diagnosed with cancer and now we're doing the surveillance, if she has a dense breast, really it's very challenging. Also, on the other hand, there will be high rate of false negative and false positive findings, meaning that those women with dense breasts will be more recalled for a finding that's most of the time benign, whether it's biopsied or not. That's why there has been some recent changes in the last few years when it comes to reporting breast density. In the past, you used to see in the screening mammogram report only two entities. Either the density is more than 75% or less, and this is what we entered in the data of the ICMS for OBSP. But in the past 2 years or a year and a half, there has been a decision that we will have to put the 4 categories. We call them the ACR 4 categories of breast densities: A, B, C, and D. A being the fatty breast, B being scattered fibroglandular densities, C being the heterogeneously dense breast, like you still see a lot of fibroglandular densities, but you'll see some fat as well. And then D is the extremely dense breast. And as I showed you earlier, it's way easier to see the cancer developing in a fatty breast as opposed to the dense breast. One thing I need to clarify for you guys, because you'll also see when we recommend a biopsy, some radiologists will categorize the recommendation for the biopsy, like, we have BI-RAD 1, 2, 3, 4, and even 0, 5, and 6. BI-RAD 4 being the biopsy is recommended. There are subcategories A, B, and C, because we want to show how high or how suspicious is the lesion. So we call, for example, for A is low suspicion, B is moderate suspicion, and C is high suspicion. This is completely different from the subcategories of the breast density. So that's very important to note for the non-radiologist. So I'm going to stop here to take a few questions before I go to supplementary screening. If you have any questions about the breast density. Alternatively, we can continue with the talk and I can take the questions at the end. So Becky, you decide. based if you can see hands raised or
Perfect.
not,
That's
because I
great.
can't.
So I actually had one question, and then we'll
Please.
see if anyone else has any questions, or Caitlin might want to chime in. I just wondered if patients can, like, if there's any other way other than radiographically to tell breast density.
Oh, you mean clinically? Anything that's, you know what? That's actually another, I wouldn't call a myth. Like sometimes women will have clinically harder breast than the softer breast. That doesn't at all, in my experience, correspond to the density. Like, having said that, we know that younger women have harder breasts, or like more firm, if you will, compared to the older. But honestly, you can have an older woman with a soft breast but very dense breast. So I've seen all that together. So I would say clinically it's very hard to say, to predict if the woman's going to be which category of these 4 categories. It's really, you really have to see it on the mammogram. And even more now, I don't know if you're aware, there are some AI softwares that would objectively measure the density, because, for example, you can be dense behind the nipple in the retroareolar region and the rest of the breast is fatty. And now, like, yes, it is scattered fibroglandular densities, but because of certain condensation of breast tissue, the AI would decide to call it heterogeneously dense. So that's why now we're moving from just the subjective opinion of the radiologist towards more an AI kind of software that will measure the density in a very reproducible, objective way, because this way we can categorize women who's going to be, we're going to talk about that coming into the supplementary screening, and kind of the woman would know her risk factors. I hope that answers your question.
Yep, that is perfect. And then there's one other question in the chat that actually probably will tie into the rest of your talk. So the question is from Dr. Dewan, and it's, how often do you recommend mammography in grade D? Also, will MRI be needed before biopsy, or is MRI needed before biopsy?
Great questions, and this is going to be answered shortly in the next few slides on the supplementary screening based on the guidelines. And basically, yeah, dense breast, just a quick answer to this is that the dense breast usually gets an annual screening, and the recommendation that the supplementary screening for category D, they can have supplementary screening either with ultrasound or MRI. If it's with MRI, it will be every 2 years. So now you can skip the second part if you want, but like, let me just quickly go through the evidence. I'm going to share the screen again. Okay, can you see my screen now?
Yeah, we can see it.
Thank you. Okay, just to give you some background, there was a publication by Ontario Health. This report is very important to read. You can find it on the Health Quality Ontario. If you Google it, I put the link here at the bottom. But like, if you Google it, even you will find it. It will come as the first link, basically talking about the final recommendation for supplemental screening as an adjunct to mammography for breast cancer screening in people with dense breast. So the recommendation is, Ontario Health, based on guidance from the Ontario Health Technical Advisory Committee, recommends that publicly funding for supplemental screening as an adjunct mammography for people with extremely dense breast. So we're talking about category D. And I just want, again, to clarify an important point here, the word adjunct, because we see patients coming in, they don't want to have the mammogram and they want to jump into the ultrasound or MRI only. But that's not helpful. That's not part of the policy. It's mammography is the baseline. It's the tool, and the recommendation is to have those MRI supplementary screening tools, whether it's MRI or ultrasound, on top of in addition to or adjunctive to the mammography. So I really wanted to emphasize this point. And also, we got an updated info email from Ontario Health in April 2024, giving us, again, the background and the history on what the panel of experts have recommended. And just to give you an idea who was sitting in the panel of experts, it was breast imagers, primary care, and health equity experts. And they came up with the fact that the recommendation will be only for the BI-RADS D density, because earlier in March, as you can see in also some of the takeaways that we took from the report that was put forward to get a commentary from the health community that deals with mammography and dense breast. So they looked at, they considered the clinical, the economic, patient preferences and values, ethical evidence for people with dense breast, and they said they want to include both heterogeneously dense breast and people with extremely dense breast. And just to remind you, those are category D and category C. Then the evidence showed that supplementary screening for the dense breast detects more cases of breast cancer and fewer interval cancer that we talked about. However, there was the evidence showed that there was no impact on mortality. Now, I just want to jump into showing you the fact that basically the evidence for other tools such as contrast-enhanced mammography was not actually enough to basically, because we use now in the province, we use contrast-enhanced mammography for diagnostic tools, but now it's not approved yet for screening. We use screening mammography 2D, 3D, which is tomosynthesis, and MRI. I just wanted to quickly show you a few cases so that you can see the difference between the fatty breast, where basically here you can see the speculated mass very easily. On ultrasound also it's depicted very well because it's big enough. While here, this is a woman presenting with a palpable lump, but the idea here, I know this is a diagnostic mammogram, but I just want to, for the visual appreciation of dense breast, really you can see nothing, correct? Like on the mammogram. But we went by the area of palpable, did the targeted ultrasound, and there was a mass biopsied. It turned out to be cancer. However, because it's very dense breast, preoperative evaluation is to do breast MRI. And that's the area that was biopsied here on the right. It turned out that there's an enhancing mass on the left. Patient was taken back to ultrasound again, and it was cancer. Another interesting story for a patient who is a 43-year-old known to have breast cysts, ended up having bilateral screening mammogram. Like for the breast with the cyst, it was diagnostic, but the IHF where she had her ultrasound decided that they were going to do screening for the right breast, which was asymptomatic at the time. And they found this questionable area of hypoechoic mass, the lymph nodes, and that was done during COVID. The lymph nodes were like enlarged in the sense that the cortex is suspicious, 6 millimeters. Then she went for diagnostic workup, looking at the mammogram. Again, the cysts are noted that on the left breast, which she's known to have them, but really we couldn't see much on the right breast that would correspond to the suspicious finding that was found only on the ultrasound. Then we took her back, and basically the mass is the same, and she basically got the sorry, I think I'm going backwards. Okay, she got the biopsy, and this turned out to be cancer, and MRI actually confirmed she had multifocal disease with lobular cancer, ended up with bilateral mastectomies. But the takeaway here is that ultrasound, when it's in screening, can detect some lesions. That's why it is one of the approved modalities for screening. Also, this is a high-risk patient. We will call this, I'm just going to give you a few seconds to think. Heterogeneously dense, yes. If you thought it's a category C, that's correct. She also got the MRI screening, and as you can see here, there's this tiny enhancing lesion with suspicious kinetics of enhancement that we rely on when we evaluate a lesion. We took her for second look ultrasound. We found that area, and it was cancer. That also shows how breast MRI is very valuable in finding specific and sensitive for detecting early disease, as opposed to the screening mammogram here, which is heterogeneously dense. We really couldn't see any lesion. She went for biopsy, that was cancer, then wire localization, and got the got that lumpectomy and early cancer removed. Here's an example of a very dense breast. Again, that's category D. We did contrast enhanced mammography on her, and as you can see, it's very quiet, no enhancement yet. Again, as I said, it's not yet recommended for supplementary screening as there was insufficient evidence that it will work, it would be cost effective for screening. But contrast enhanced mammography, I'd like to show you an example that it works really well for when you work up a breast issue. So this patient had right nipple retraction. So this is actually the left breast, but on the right, she had nipple retraction and calcifications. And the reason why I'm showing you the left breast, because there was a change and people thought that there is, the radiologist thought that there is probably architectural distortion. In addition to the major finding on the right here, where you can see some calcifications and nipple retraction, they were suspicious, and we recommended stereotactic biopsy. But given all the multiple complex findings between the left and right, we thought as a problem-solving, contrast-enhanced mammography would be very helpful. So looking at the breast here, this is the regular 2D mammogram, and this is the contrast-enhanced mammography. And these areas there that are enhancing are very, very suspicious, and that's actually when it was biopsied, it was cancer. And also we went and we did the as well the left breast, and given that there was no enhancement, this reassured us that the left breast actually was clear. These are the ultrasound guided biopsies, multiple areas were found. And just worth mentioning that when we did the initial ultrasound before the contrast enhanced mammography, it was very hard to see these lesions, but based on the areas of enhancement, we went with kind of targeted approach, we found those lesions and we did the biopsies. Okay, that was a quick run through a couple of cases just to give you an idea how we utilize multimodality between all the way from 2D ultrasound to contrast enhanced mammography, MRI as well. So the recommendations came to the fact that only patients with BI-RADS-T density will get the publicly funded supplemental screening. The reason being that the cost effectiveness and the budget impact of supplemental screening with ultrasound or tomosynthesis or MRI were more favorable for those group of patients, like the extremely dense, the BI-RADS-D, but it's less favorable when both combine C and D together. That's why we're starting with the supplementary screening for D. Some of the benefits, just to quickly go through them: increased sensitivity of the breast screening, increased breast cancer detection rate, and the decreased interval cancer rate. There are obviously the obvious risks, which I think you'll have them anyways regardless, even if you don't have the supplementary screening, in my own opinion, where basically decreased specificity, increased abnormal callback rates, which is the BI-RADS-0, and the increased false positive results, meaning that you're calling the patient for a finding that turned out to be nothing or benign on biopsy, which is sometimes they call it overdiagnosis. To remind you again, this is BI-RADS-C, the heterogeneously dense, and this is BI-RADS-D, the extremely dense. So now that we know that supplementary screening is good, we need to do it. Keep in mind that I'm going to talk about that we're going to open the gates for another group of women under 50 to come in for screening between the age of 40 to 49. We're working in parallel also to introduce supplementary screening. Our healthcare system will be flooded. So that's why we're taking it step by step. We're going to have a short-term plan and long-term plan in terms of our approach and strategy to implement all these excellent recommendations. So for now, as you know, we only offer annual screening. To answer the question that I had earlier, we offer annual screening with mammography only for category D. And the OBSP will continue to recall them every year. And then the long-term plan, we will offer the supplementary screening as the following: basically mammography and MRI once every 2 years, or mammography and ultrasound every year. But this will take some time. and there is kind of an approach for this. Still, women need to understand the role of supplementary screening. What are the risks? What are the benefits? But again, until we're ready and see how the introducing the women with 40 to 49, which by the way, as we talked about, the younger the woman, the more dense is the breast, probably we will have more category D, which means like we will need more supplementary screening. So the long-term approach, we will implement that in a multi-year fashion, in a multi-year initiative, and we will consider the following factors. Variability in access to supplementary screening modalities across Ontario. Some, as you know, some hospitals or some centers don't have access to breast MRI. And if they have the access for breast MRI, they don't have access to breast MRI guided biopsies, and they have to refer outside. So we need to kind of tweak all these processes and working collaboratively on a region, in every region. And then what's the impact of that modality on the system? Is it going to increase our callback rate, or is it going to lower it? Can we leverage some other combinations of modalities together? And potential legislative and regulatory changes, because we really need to stick to certain kind of practices before we jump into this, I would say, unknown amount of referrals and volumes so far if we open the gate without having a good calculations. And then there will need to be, to help us as always, like the digital approach, whether it's with the IT infrastructure, data collection, reporting, and correspondence, and this again will be phased. So as I said, it's a multi-year process. Until it's implemented, the current practice is unchanged. I just want to clarify that it's unchanged, and it will all depend on each center. What we're trying to say that in the OBSP mammography report, there will be no change, and still the radiologist cannot automatically say this patient, because she is BI-RADS D, now she is eligible for supplementary screening. Now the primary care can obviously ask for supplementary screening. You can send a referral. However, don't expect it that it will be done, because the priorities will be basically, I'm just going to quickly go to another slide. I think I skipped, which is important. Basically, I'm sorry, but like I can say it, basically, you can send the requisition, and if the center can accommodate that, it would be great, but this will be based on prioritization, provided that the high-risk women are getting they're not going to be delayed, the diagnostic workup is not going to be delayed, the preoperative breast MRIs are not going to be delayed. So if there is room at that center, it happened to be that they have more capacity, probably you will find the radiologist or the navigator will fit those patients in. But until then, until we get a direction from OBSP that this is going to get started, so far the process hasn't changed. I'm going to stop sharing because I think I may get some questions, too much information. Some of them are confusing. Vicky, you pick, you let me know which questions need to be answered, if any.
Sure. There's no questions right now in the chat. If anybody has a question, please just put your hand up and feel free to ask it, or to put your question in the chat so that I can ask it.
Okay, I'm gonna share. Any expected change between 40 to 50? Okay, I'm coming to the 40 to 50. What type of contrast is used? It's the same contrast that we use for CT, believe it or not, which is really good, because whatever criteria and policy we have for CT in terms of allergies and access, IV access and training, it would be very similar to the CT. I'm going to continue with the last part of our presentations, and we'll take more questions or discussions or comments. I just put screening under 50, but it's really the 40 to 49. And as we know, in March 2024, basically there was a decision made that we will expand the OBSP eligibility criteria to include women 40 to 49. Now, the question was, did we used to screen women under 50? Yes, we used to, but like, as you know, this was based on a referral from a primary care physician or any other clinician. Patients cannot self-refer. So that was kind of a more equitable approach to allow women to come in and refer and get a breast screening. So this is the purpose of this presentation, and this is actually a template that was given to us in the leadership for OBSP to share with our colleagues. And if you have any questions, definitely we can escalate this and take it up, but I'm happy to try my best to answer any of the questions on the upcoming slides. So all of you are familiar with the OBSP program. It started in 1990, and it includes women 50 to 74. We have data, we have correspondence. It has two arms, the average risk and the high risk. The average risk, basically, they will get an annual mammogram. Maybe I can go to, yeah. The average risk is 50 to 74. They get a mammogram every 2 years, but they can be having the mammogram every 1 year if they have high-risk pathology lesions, which basically, let's say a woman have a papillary lesion or LCIS, any of these kind of pathologies, it will make like it's automatically they will be recalled for annual screening. Also, if there's a positive family history with some specific criteria, sometimes the radiologist will recall this patient for an annual screening mammogram regardless of the density. And as I said, currently, if the woman is found to have BI-RADS D, she will have an annual screening. And then for the higher risk women, they will have annual screening mammogram and MRI every year, starting at the age of 30. Okay, so now currently the current practice is that the OBSP encourages women between 40 to 49 to have their discussion, to make their informed decision, by having that discussion with their primary care providers regarding should they get screened or not, and how frequent they will get it. And that would require a referral, as we talked about this. But starting in the fall, there will be an improved process. Women will have more equitable access by self-referral, and then they will benefit from the organized screening program, which is basically correspondence. But that's not going to happen right away. As soon as we open the doors for screening in the fall, there are 2 phases that we're going to talk about. But also, why did we move to that step? And as you know, many of us were advocating for this because we want to follow some other provinces in the country, in Canada, and also in the United States, start at the age of 40. So we found out, based on the evidence, that there's slight increase in breast cancer incidence in females ages 40 to 49 in Ontario from 2012 and to 2018. Also, younger women are more likely to have been diagnosed at a later stage. Part of it is like sometimes we really try to rationalize this, that, oh, this is probably benign diseases happen more often in younger women, but also given all the other factors that I talked about, the cancer might be masked. And if or women don't have access to screening, and we're going to see this as well because there are inequities in mammography screening participation in women between 40 to 49. And those with no mammogram had a higher percentage of people in the most materially deprived communities, in the lowest income neighborhoods, and in the most ethnically concentrated communities. And this is our data in Ontario. And on the other hand, when it comes to modeling results, which basically comes from the United States Preventive Service Task Force, they do say that the averted. Okay, let's just put that into perspective. From 50 to 74, you will have probably 7 breast cancer deaths averted for 1,000 female persons screened. But starting at the age of 40, if we start the screening at the age of 40, only 1 to 2 additional breast cancer deaths averted over a lifetime. So the rationale that this need informed decision making is that the potential harms of screening for women 40 to 49 is probably leading to unnecessary follow-ups and testing and overdiagnosis. And I'm adding my own personal piece here as a radiologist. Basically, they're trying to say, oh, maybe you're not going to benefit that much from screening starting at the age of 40 because there will be more overdiagnosis, more callback. But again, you know what? Like, still, it's beneficial for these women, and some women would take that very small likelihood of overdiagnosis or false positive. She will accept that, provided that her cancer will be discovered earlier. And again, this is some of the modeling results on the evidence where basically there will be mortality reduction and death averted based on per 1,000. It's just probably 1 to 2 when we start at the age of 40, increased false positives, and a little bit of increase in overdiagnosis when it comes to screening versus no screening. Now let's look at some data when it comes to the percentage of projected breast cancer cases by age at 2023. The highest group obviously is between 60 to 69. As we know, breast cancer has two main risk factors, being a woman and getting older. So we know that. So it comes at no surprise that the age group 60 to 69, followed by the 70 to 79, then 50 to 59. But look at the 40 to 49. 13% is not a small percentage. And this is like the prime age for women, busy with kids, most productive in the community, and it's impacting the whole family. Not that the younger or the older women are not as important, but what I'm saying is the impact, the palpable impact of getting diagnosed or being excluded from an organized screening program is very, well, it's like, will have a huge impact in general at any population. So that's why I think it's very, very important to include this population in the screening, in the organized screening program. So the patient journey would start, we still think, given all the, we are acknowledging all the risks, or I would say the harms of screening, this is worth having an informed decision. So patients will have to understand the breast cancer risks, the patient's values, preferences, to make an informed decision when they discuss it with their primary care physicians or calling Health 811, or again, primary care physicians like yourselves, and prevention specialists. Then they will get the mammogram, and that would be booked through OBSP. And there will be a web tool or by calling directly the OBSP site. And there's also Ontario Health Contact Center. Results, the beauty of being part of a organized screening program, the results and follow-up will happen. And then there will be a follow-up care after that. This is only the OBSP results, like the Ontario Health will be responsible for following up in phase 2. That's very important to realize, because so far, if the woman gets screened in phase 1, still they will have to follow up with their primary care physicians. So women will be encouraged to have a discussion with their healthcare providers, make an informed decision whether to screen based on their cancer risks, harms, benefits, and understanding and their own values and preferences. They can still self-refer to OBSP, and the same screening eligibility in terms of the interval, like will follow, just like for the 50 to 74 that we talked about. Okay, similar criteria, whether they are average risk or increased risk. This is not the high risk program. Increased risk is different than the high risk program. And then, as I said, there is a phased approach with some enhancement, including the implementing, basically to implement the correspondence, normal results letters, recall letters if the patient has an abnormal finding, and this will be done in phase 2. Also, the following activities are very important to keep you informed of what's going on in the background, to assess capacity. We really want to know how every region is doing, what are the bottlenecks, how are they going to be impacted by the increased number or the expected increased number of screening, which will basically have a downstream increase in diagnostic and biopsy. So what we're doing, there was a survey sent out to all the facilities that perform breast screening with mammography. They collected data from the OBSP sites to determine screening mammography and breast assessment capacity. They developed public-facing online portal to inform screening mammography appointment wait times, which is great, and we're very proud as a region in the Central East. We already have started that, so we encourage you to visit that website. So Caitlin, maybe you can drop that link in the chat so people are aware of it. I keep getting questions about that link. And then we will work with provincial partners, Ministry of Health, Health Force Ontario, to develop strategies to address capacity constraints once they are identified, to offer support and help, and then continue to monitor and report on the service volumes and wait times so people are aware of where are the pain points. So the OBSP sites, here are the planned resources on the program changes. The screening policy guidance documents for screening people ages 40 to 49. There will be a document on the frequently asked questions and how to address them. For primary care providers, you guys are going to have informational tool to support breast screening conversations with patients ages 40 to 49 with frequently asked questions, and the Ontario Health website updates. Pre-launch presentations at provincial, regional webinars and presentations. And I'm very proud of our team that they are taking an earlier steps and getting those conversations started by this type of webinars to see what sort of concerns and comments are coming from the most impacted colleagues. Other than the radiologists would be the primary care physicians. And of course, the multidisciplinary breast cancer care team, whether it's surgeons and oncologists, they will all be impacted. As for the public, the breast screening information sheet for people ages 40 to 49 will be available, and with the ability for people to discuss breast screening with provincial specialists or call 811 Health, and then access to online information about the screening appointment wait times at OBSP sites, so patients can refer themselves to the sites that have the lowest wait time. So all resources will be available by the program launch in fall 2024. So stay tuned. Thank you very much for your attention, and I'm happy to take more questions, comments.
Thank you so much, Dr. Shaheen. We do have some questions in the chat, and there are some questions around MRI screening specifically and the rollout of the 40 to 49 age group. So why don't we do the rollout, because we're on that topic now. One of the questions is, so any expected change between 40 to 50 as we start from 40 years? I think you addressed that. And Dr. Dewan, if there's something more specific, just add it into the chat. Another question is, for those without a family physician, is there a process for referral to a breast diagnostic center or surgeon? So I'm assuming this is for patients who self-refer. Right?
Yeah,
and
yes.
Yeah, so if you want to go through that.
Actually, that's a great question, and it's a problem for radiology in general. But when it comes, luckily, again, that's the beauty of being part of an organized screening program. As you know, at least I'm speaking for our region, every OBSP site should have a champion physician, so that those unattached patients that have no family doctor, there should be someone following them up with the results, especially if they are called back, and then try to get them into the journey of multidisciplinary, whether through a breast navigator or not. But every single site has a champion physician that will own that unattached patient. Does that make sense? I think that's, the unattached patients is not just the 40 to 49. We're still facing it for 50 to 74. So it's not like a new problem. I mean, it's a new problem after COVID that has been almost like a snowball after COVID, where a lot of patients became, for some, the numbers has increased. And we're seeing more of that, not just for breast referrals, but for other diagnostic imaging. But at least for the breast part, we know that each site will have either primary care or even a nurse practitioner will be looking after that patient until that patient gets into the circle of multidisciplinary care that's needed, or maybe even return that patient back to screening.
Excellent, thank you. And I know I can just comment on that too as the regional primary care lead. We're working on that certainly in each OHT region at having that champion who will take care of those patients with the abnormal results. It's not actually a lot, fortunately, but there are those pieces. One of the things we're doing in Durham region, just to provide an example, and this is because I also wear a primary care OHT lead hat in Durham region, is that we've developed a couple of unattached patient clinics regionally through the region, and we're in the process of coordinating care for this exact thing. These unattached patients could then be seen in these clinics and followed in these clinics if they need to, so that they're not needing necessarily to seek urgent care and things like that.
Exactly.
Yeah. So we're working on solutions. Ultimately, it'd be nice to attach everyone, and we wouldn't have these problems. That's obviously my big goal. We'll get back to some of the questions. So we'll do a few questions around screening. So one of the questions is, as primary care providers, what should we be doing now for supplemental screening for BRADS D? And I would add to that BRADS C, because it's not just the extremely dense, it was the very dense that also had increased risk of cancers. Should we hold off on ordering supplemental screening until OBSP officially incorporates it?
I would say the short answer is yes, but there's a longer answer. First, let me clarify, because that you have mentioned DNC. Yes, DNC in the initial report that was issued in March 2023, they lumped them both together. But as I clarified in the evidence, they found the cost effectiveness works well for the extremely dense. So for now, the program is going to support the publicly funded supplementary screening, unfortunately, only for the extremely dense D. So I would say if you send a requisition for supplemental screening for C, it might be rejected from the centers, because it's not whether now before the policy is implemented or after, it's going to be a challenge to get that done. I know, unfortunately, patients will go and pay out of pocket to some private clinics, but we don't recommend that. They end up coming to us again, and it's just not good quality of care to try to find something that and repeat it as well. So I would say it's easier to stick with the policy and follow and see, especially if the patient doesn't have any other risk factors. That's one part of the question. The other part is, what should we do now? Now, as I said, based on the information that we have from OBSP, nothing has changed until we get the green light that supplemental screening now will be started. As I said, part of the discussions, what if we get requisitions from the primary care physician saying, hey, this is Category D, and I heard that those patients, the recommendation is to get an ultrasound and MRI. Can you guys do it? If the facility that you're dealing with is accepting it and saying we can fit them in and probably have some opening hours that are, extra, that's not going to impact their own data in terms of fitting the patients who need it more urgently, as the list of patients that I went through, whether it's diagnostic, whether it's high risk, then they can fit it. So I think for now, it's a more discussion between the primary care physician and the center or the facility that they are referring to. So maybe you can send the requisition, but I would like you to lower the expectations in terms of when they're going to get done, and if they're going to get done without getting the green light from OBSP. I know this is not the perfect answer, and I was worried about that question.
Thank you. There is a question in the chat about the MRI screening with contrast. Is there any evidence about deposition disease with annual contrast, like like we're using with MRI screening for breast.
Okay, just to clarify, so I guess the question is, how breast MRI gadolinium, which is completely different contrast than the IV contrast that we inject, which is iodine based for the contrast enhanced mammography. Are they asking if there is residual deposits in the body when it comes to contrast enhanced mammography? Just to confirm.
Confirmed. Yeah.
Yeah. So not that I'm aware of. It's there's no known residual kind of contrast in the brain, for example, which we found with the gadolinium. But again, the same risk factors that patients will have when they get a CT, contrast enhanced CT, would fall with the contrast enhanced mammography. Most importantly, impacting the renal function, and those who are diabetics and on metformin, for example. We will go through all this with the patients and make sure that they don't have these risk factors and they're aware of it. They sign on a consent before they get the contrast enhanced mammography. And as I said, this is not for screening. We use it for diagnostic and problem solving issues, because usually those cases that have complexities and need a problem solving, we used to send them to MRI. The idea of having the contrast enhanced mammography is that we're saving the woman from going to MRI, which is a longer scan. And this one will give her one-stop shop. She'll have the contrast enhanced mammogram, the ultrasound, sometimes the biopsies, all in one visit. So, and we are freeing the capacity in MRI, which hopefully down the road, that means more spots for screening or more spots for other MRI scans, where we had, we as a province suffer from long wait times for MRIs in general.
Excellent. Thank you for that. And thank you for clarifying. There's a question about the frequency of mammograms. So the question is, why do we only order annual mammograms on patients with a past history of breast cancer? But I think the add-on or expansion of that question is, what are the recommendations for frequency of breast cancer screening or mammogram screening? Is there benefit to screening premenopausal women or women on hormone replacement therapy annually rather than every 2 years?
This is an excellent question, and we have to note a couple of things here. Women with history of breast cancer, like survivors or that need surveillance, are not part of OBSP. So I just want this to be clear. So unfortunately, they don't get the correspondence. Yet the annual screening mammograms is part of the best practices guidelines, whether the patient is being followed up by primary care, oncologist, or breast surgeon. This is the way it's done, and the recommendation, at least an annual screening, is the base minimum, is the surveillance. For example, at PRHC, where I practice, we decided that tomosynthesis would be offered for these patients as an enhancement, and if you will, it is a supplementary imaging to increase the chances that we will see, because we know that these women are at higher risk of getting breast cancer. So basically, we are offering them kind of an upgrade to just the regular 2D screening, if they agree for it. That doesn't mean they don't get the 2D. They get both the 2D and the 3D screening. As you know, they are not part of the OBSP program. So also the women with the breast implants used to be, until last year, not part of the OBSP program. And with advocacy now, they were added into the program. You never know, maybe down the road. Again, don't quote me on this, but it's something that we need to advocate for, where basically these women need to have to be part of an organized screening. And if there's supplementary screening offered, given the higher risk compared to the rest of the population, they are probably worth getting a supplementary screening. But I'm not aware of any work being done on this for now, because there's a lot of variables, as you can see. But it's an excellent question.
Excellent. Thank you. I don't see any other questions in the chat. I don't know if anyone else has any Any other questions? I don't see any hands up, but certainly if there are, feel free to put your hand up if we missed anything. And I wanted to take an opportunity to say thank you. Thank you for providing us with this overview. It's a lot. There's a lot to take in, right? With the breast density information and also the upcoming changes. But it's nice to be prepared as patients are hearing about changes they're starting to present. And Caitlin has her hand up.
Sorry, I just saw a couple more questions in the Q&A section. So one of them, are there any differences in the new recommendations in patients with implants?
Well, yes, the new recommendation, but those are older recommendations. I didn't bring them up just because I assume this has been taken care of earlier. So now women with breast implants are part of the OBSP organized screening program. They will be imaged based on the same policy. They will have the correspondence. They were excluded in the past, as you know. So the change is that now they are part of the OBSP program, and they still get the annual screening.
And then just one more here, and I think you did talk about this as well, but just highlight it again. With the age of 40, would we expect higher numbers of dense breasts and thus more recalls and supplementary testing?
Correct. So that's why we were talking about the fact that a need for informed decision making is the fact that when it comes to screening those women between 40 to 49, given the fact that they have more dense breasts, when we compare this cohort with an older woman of cohort between 50 to 59, 50 to 74, we will find probably denser breasts between 40 to 49. And that means when you have more dense breasts, we already went through this, you're going to have more false positives, more recalls, and more late-stage cancers. So supplementary screenings is going to be needed even more between the 40 to 49. And that's why I think this approach of being very careful and phased approach over multiple years for implementing the supplementary screening is that we really want to reassess the situation once we start the screening in the fall of 2024 for the women 40 to 49, and just to see the amount of referrals and volumes and how it's going to impact capacities and certain facilities across the province. And then we're going to come up with a plan on how to support and fund, for example, certain areas that need our attention when it comes to this age group that will need more supplemental screening. We cannot just offer them screening and say, yes, if you have high density, you're at high risk, and do nothing about it. But I think this multi-phase approach is a wise approach, and only we will know in real time when we implement that, and the supplementary screening will come. I hope that answers the questions. I'm not sure if it's directly answering it. Whoever asked the question. And I see Maria Moraka in the chat. Maria, please email me after this. That's great. Any other questions? Yes, Simpatico works. I'm more than happy to give you 1 minute. Oh, it's 1 o'clock. Yep. So I wanted to give them 1 minute back into the sun.
I don't see any other questions in the chat at all. And I just want to say thank you. This was excellent. And I also wanted to share for anybody who is on the call who hasn't yet received an email about it, Durham OHT is hosting a primary care networking event on June the 4th. And so we would love to have anybody who is interested come and join us, even if you're from outside of Durham region. You're welcome to join us. And that is June the 4th, and we'll share that by email as well.
Thank you.
But thank
so
you,
much.
Dr. Shaheen. And if anyone
you,
has any
Dr. Wade.
questions that come up after, please do send them along and we will share them with Dr. Shaheen.
Absolutely. I'll be more than happy to help them to the best of my capacity. Thank you. Have a lovely weekend, everybody.
Thanks so much. Thanks,
Thank
Rula. I
you.
really appreciate it.
You take care. Bye-bye.
Care,
Thank you.
everyone.